Okay, let me know when.
Yeah, let's start.
Okay, just move this out of the way. Okay, hi everyone. I'll be giving a hopefully concise version of a very interesting case that I think a lot of you might be interested, or a lot of you might have encountered or come across. Sorry, that you might have encountered the patient in the hospital or been involved in their care. So we have a 33-year-old woman who came to the hospital complaining of 2 days of dyspnea. She had a history of HIV/AIDS, polysubstance abuse, and was coming in with a 2-day history of dyspnea that had been preceded by smoking marijuana. She said it was getting much worse, but was denying actually having a cough or any fevers, chills, or rigors. Reported having a weight loss, an unintentional weight loss over the past month. And denied having any recent travel, wasn't sure about sick contacts, and did report being only kind of partially adherent with her ART and her other medications. And when EMS brought her in, they reported that she had been 86%, saturating 86% on room air. Her review systems was positive for very frequent non-bloody diarrhea that she'd been having for several weeks, and she didn't have any abdominal pain with it. Medical surgical history. So, when she presented, we knew she had a history of HIV/AIDS. Her most recent CD4 count had been 113 in September. She has history of latent syphilis, polysubstance abuse that had been complicated by psychosis. No family history of malignancy. Not sure about TB. She was coming from a shelter. She's a smoker. She denied ever using IV drugs. And then questionable adherence with Biktarvy, quetiapine, and Augmentin. And at the time, no known drug allergies. So to put this case in context, it's important to know the timeline. So in July of this year, she was admitted to Mount Sinai West with respiratory sepsis and this substance-induced psychosis. She had a chest X-ray which showed these ill-defined opacities. She was given penicillin for syphilis and then discharged on Biktarvy and quetiapine. She then later presented in September and was thought to have sepsis either from a pneumonia or from this diarrhea which she was reporting. And she was found to have this left upper lobe cavitary lesion. She had a bronchoscopy done, which had a negative lavage, and her AFB was negative. And then she later AMA'd, but was prescribed 6 weeks of Augmentin before she left. And now, it's October, and we're seeing her with this 2-day history of dyspnea.
Let's just pause here. Let's go back a slide. And what other questions do you have? What do you want to know more about the history in this case?
It's not exactly a question about the history, but did she have a CAT scan? Did she got a CAT scan any time during that course, like July to September?
She did, and we'll look at it very quickly.
Okay.
Where is she from originally? Is she born in America, or is she from out of the States?
She's from America.
Rebecca, on that, why would you want to ask that?
I just think having upper lobe cavitary lesions. I know her AFB was negative, but just thinking of other respiratory diseases that can affect upper lobes, obviously like TB, but even histo or other things with her history.
Yeah, great question. But on the same lines, you asked whether the patient's from overseas. Any more questions you could to elicit a history of exposure to TB?
If she's been incarcerated.
Other questions?
I mean, if she served in the military.
Okay, institutional. Yeah. She's been in an institutional setting, been incarcerated, homeless. So they're not just country of origin, but there are other questions also which help you elicit possible exposure to TB. But yeah, that's the train of thought. Good catch.
shelter too, she was coming in from. So that's another risk factor for her as well.
Yeah, and good catch on the upper lobe. That's very important. Anything else anybody wants to ask?
When was the
Patrick. Sorry. Go ahead, Matthew.
When was the HIV diagnosed? Do we know?
I don't actually know.
Any more questions you would want to ask about the HIV?
Yeah. So you said this presentation, she came in with shortness of breath. Was that July and September, or it's something new?
So she had shortness of breath in July and in September. But in September was feeling so well that she wanted to go home. So she AMA'd, and then was home for a period of time, and then is coming back with, say, like more acute or recent shortness of breath.
I see. Thank you.
Okay. So we trying to get more into this history of HIV/AIDS. So are there any questions? Obviously, we'll go into the labs and try to figure out what's the degree of immunocompromise. But are there any questions you can ask to elicit, okay, this patient has full-blown AIDS and is really immunocompromised? Anything in the history which would make that more likely? Whenever you're evaluating a patient with HIV, if you want to see if they're
for opportunistic infection.
Great, yeah. So that's important, because if this patient has had an opportunistic infection in the past, that means they have AIDS. So that's important to know. History of oral thrush, yes, thrush. That's right, Eric. So those are points in history. Anything else? Any other questions we've left out? We're talking about shortness of breath, so let's go to the social history for a second. Just press on the screen once.
Yeah, sorry. It's not letting me here. Hang on 1 second. No, hold on. Here we go. Yeah.
So smoker, can we quantify how much smoke? Because that is also important.
So going through the notes, it looked like it was maybe like I'd say a total of like 5 to 10 packets.
Okay. So, but that's also important. That's also another important question, right? Because every smoker, you can say that this person smoked 2 cigarettes a week or 2 packs a day. So there's very different implications for both. So it's important to quantify how much the patient is smoking. Okay, that's decent history. Let's move to the examination. Go ahead, Patrick.
So vitals then, she was like normal blood pressure, tachycardic to 107, tachypnic to 35, and saturating 100% on a non-rebreather mask, and was afebrile. Apparently, was pretty, all things considered, was pretty well appearing, didn't look toxic, and was really significant for the fact that, on the non-rebreather was having this like diffuse squeeze with very coarse kind of breath sounds, but didn't look toxic. So then, just for kind of the presentation's sake and timeliness, we'll pretend that the labs haven't come back and recent imaging hasn't happened. So we're going to do a quick chart review and look at the previous imaging. So first up, we have, this is an X-ray, the initial X-ray from July, which commented on those diffuse maybe opacities. I'm not sure. Does anyone want to volunteer, or does anyone want to shout out anything they see?
Yeah, we don't have to go about it systematically. Just shout out any findings you see. I mean, it's not the best film, but anything which stands out right now.
Don't worry. Okay, I know people don't want to be on the spot. So
I can.
Shabari, what were you saying?
I said, does the trachea look deviated a little bit to the right side? Maybe just a little bit. Or maybe it's just the images.
Yeah, hard to say, right? Because it's not a great film. So tracheal deviation, I don't think we could comment on. But if it is, it would have implications. That's one point. Okay. And somebody else was trying to say something.
So I see these opacities mostly in the like middle and lower lung fields and more central than peripheral. At least that's the way it looks to me.
Okay.
Yeah, I'll be honest. It's not a great film, and it's also, you know, unless I was hinted at, I wouldn't have picked it up myself. But knowing that the patient was later found to have a left upper lobe cavitary lesion, can you guys see anything in the left upper lobe or left upper zone, if you want to be specific? So there's a very subtle, if you look at it, there's kind of like a ring of opacity and then a central lucency, but again, very subtle. So this was in July, and then on that later admission in September, when it was, you know, diagnosed, and then she had the bronch. This is the repeat chest X-ray. So, you know, much better film, much more diffuse kind of opacities or haziness, I should say. And then, you know, looking at the left upper lobe, you can see there's a much increased cavity with a much better demarcated, you know, rim. And then, you know, you can see that it's quite, the wall is quite thick, and we'll talk about the significance of that in a minute. And so during that admission, Sophia, she had a CAT scan, and you know, this is more or less the same, you know, placement, but you can see again, you can see that cavity, and you can see it has that thick wall, right? So, you know, the labs are in process, the repeat imaging is in process. You know, what do you guys think is going on? Like, what's your assessment, or what are you concerned about at the moment?
Yeah, so let's talk about a problem representation. Anybody want to take a stab? We can do it together, or I can pick someone. Anybody want to volunteer? Okay, then I'm going to pick someone. Let's see. Dalgis, let's try together.
Sure. So this is a 36-year-old female with HIV and 2 previous hospitalizations for complicated by sepsis, now presenting with acute onset dyspnea, hypoxic, and evidence of ring enhancing lesion in chest X-ray, concerning for an opportunistic infection versus TB, even though it was ruled out before.
Great. So yeah, we know who the patient is. It's a young patient, young female with the comorbidity here. I would say, I wouldn't even say HIV, I would say AIDS, because number one, the patient's compliance is very poor, the CD4 count was low, there's some history of diarrhea, there's potential lesion. So the patient, I would consider this patient as frankly immunocompromised and as a patient with AIDS. So this patient is coming frankly hypoxic and respiratory distress. So hypoxic respiratory failure with a left upper lobe cavitary lesion. So that would be my problem representation. Good. So we know the patient. And how about the time course? Would you be able to say whether this is acute, subacute, chronic?
I think we can say subacute because it's been for 2-3 months now.
Definitely, the lesion has been there. So I think the lesion also gives us a little bit about idea about the chronicity, while the symptoms are also subacute, but the lesion, the fact that the lesion was there means that there is some chronicity to it, and it's not an acute, because that would have different implications, right? An acute cavity is very different from a subacute to a chronic cavity. So yeah, let's go ahead, Matt.
Okay, so yeah, so I think Douglas, I think you're spot on. So, you know, let's just get the definition. So cavity versus a cyst. So a cavity is a gas-filled space, and it's a lucency, meaning that it you know, it's like a black shadow on an X-ray or a CT, and it usually has a well-defined wall. And you know, these are arbitrary numbers, but it's usually greater than 4 millimeters. And then Douglas, like you said, you know, acute, subacute, chronic. So, you know, again, arbitrary, but saying that acute is less than 12 weeks and chronic is more than 12 weeks. And that's, you know, obviously more convenient when you have prior imaging. Cysts then, on the other hand, are, surrounded by epithelial or fibrous tissue, but they're usually very thin walled, so usually less than 2 millimeters. And it's an important distinction to make because it helps you work up your differential. So, does anyone have a framework or kind of like an algorithm in their head for how they think of cavitary lesions, or where they start in terms of what to order? Does anyone have a mnemonic?
Or just broad categories for differentials, like what could cause a cavity?
You have to think infectious anytime you see a cavitary lesion, right? So I always try and think what I can't miss, and cavitary, you always worry about TB first, especially if there's any, history of travel or if the patient's immunocompromised.
Yeah, exactly. No, you're exactly right.
Yeah, I think
there.
I'm thinking of differential based on like infectious one, malignancy, systemic diseases, sarcoid. And infectious, you have like Aspergillus, not like bacteria will be the big thing, but abscesses, bacteria, mycobacterium, and then there's like the other fungus, Histoplasma, Aspergillus, Aspergillosis mainly.
Yeah, exactly. And yeah, so there's a very big differential. And the reason I bring up mnemonics, I'm a big fan of mnemonics, and I've seen this written in several doc rooms and in lots of places. I think it might have been like Deep Batatia's like graffiti tag or something, because it seems to be everywhere. So the mnemonic is cavity. And is anyone familiar with this, or does anyone know the components? Okay, so we'll go through it really quickly. So it's like you're saying, it can be cancers and autoimmune things, like systemic things. So cancers, autoimmune, vascular infection, trauma, and youth. Being a big fan of mnemonics, I actually find this mnemonic pretty useless, because it's just a list of very broad differentials. So cancers, so it's typically like bronchogenic or squamous cell. Autoimmune is GPA or rheumatoid arthritis. Vascular is actually PE, it could be septic or a regular PE. And then infection, that differential is massive. Trauma is things like pneumatocoel. Again, I've never seen it. I'm sure it's on the differential, but I'm sure you'd have lots of hints. You wouldn't need this mnemonic. And then youth is like these congenital abnormalities. Again, so far down the differential that this mnemonic is useless. So if you were to get any use from this, I think like Matt said, you should always consider infection first. So separate things that are infectious and then non-infectious. And there's no, you won't find a really good algorithm on UpToDate. I did find an algorithm that was published in Chest in 2018. And how they recommended or advised going through it would be ruling out cavitary mimics. So a cavitary mimic is anything that's not a cavity, but you think might be a cavity. So for example, is this a cavity or what is this? Anyone?
It can be an emphysematous lesion.
It can be a what?
Subpleural blood.
Emphysema, ebola.
Yeah, so it could be, and we'll look at those in a second. But this actually does have a wall. You can see that opaque, very thin wall. So remember that one of the big differences is that the cysts have a thin wall, and then the cavities have a thick wall. So this is just a cyst. Then this, Sophia, is you can't actually see any wall. So this is actually just emphysema. You just see lots of lucency, dark, hollow, empty space. So this is just emphysema. Now this is a little bit more complicated. These are so on the left you see bullae, and then on the right you see infected bullae. So this is, the way you're able to make this is you have, prior imaging that just shows the bullae, and then on the right hand side you can see there's like this air fluid level, so it's a new infection. But still not a cavity. And then this is actually just bronchiectasis, okay? So not healthy lungs, but not cavities. So once you've decided that they are true cavities, then like Dalgas had pointed out, you want to know about the duration. So acute, subacute, chronic. So if it's acute and we're saying it's less than 12 weeks of either objective imaging or symptoms, then we want to start thinking about infections. So the differential is huge, as you can see. And a lot of the risk factors are overlapping. So I'll try to separate some of the things that are kind of more unique for those certain causes. So looking, say in the middle, a lung abscess. So this is someone who maybe has like alcohol abuse, who maybe blacks out, or who has, poor dentition and then has seizures and aspirates. On the left, cryptococcus, the pigeon droppings is the kind of the famous one. Then the bottom left, coccidioidomycosis is, again, from the history, are they from the Southwest USA, Central South America? Up the top right, you have the necrotizing pneumonias, again, people who are, alcohol abuse or on long courses of steroids or have diabetes. Septic emboli, so these are, the patients who live in the ICU for the longest time, have central lines, have pacemakers, are, very, very sick. And then aspergillus and mucormycosis. The reason I put them together is that their imaging is very similar, their risk factors are very similar, but aspergillus is beta-D-glucan positive, whereas mucormycosis isn't. You'll notice that TB isn't on this differential because while TB can cause acute cavitary lesions, it tends to be more chronic cavitary lesions. So, this would help frame your differential and your workup. If it seems more chronic, again, you want to think about infectious causes. And again, it's a huge differential. But like Matt said, you want to think about TB first. So up the top right, you have TB, with their risk factors. Are they from an endemic area? Do they have HIV or AIDS? Then, the other types of mycobacterium, do they have structural lung disease? And then it's really, a wide differential. But then, chronic aspergillosis, do they have structural lung disease? Have they had radiation therapy, cystic fibrosis, things like that? The two down the bottom, histo and blasto, kind of similar areas, except histo is from birds and bats and blasto is from soil. I'm not sure if that would be able to help, unless they're a chicken farmer, I'm not sure that's going to help your differential, but things to think of. And once you've ruled these out, then the next step is to think about malignancy and autoimmune conditions. So in malignancy, if it's a primary tumor, it's going to be solitary and it's going to be in the, most likely the upper lobe. If it's metastatic, it's probably going to be bilateral and you're going to have several of them. Autoimmune, the two big ones are rheumatoid arthritis and GPA. Rheumatoid arthritis, I'm sure some people present with cavitary lesions, but most people will have joint pain. And you'll be able to, get a bit of a history, and then they'll also test positive for antibodies. GPA, again, they might have epistaxis or a bit more of a history. And again, you test for C-ANCA. So this is the CT from September that we saw a little while ago. And now that we know how to tell the difference between a cyst and a cavity, cyst and a cavity, I just want to highlight down here, you can see that, there's this lucency, but there's no wall. So that'll be, a cyst or a mimic, it wouldn't be a cavity. And then over here as well, you can see there's, a cyst, but if it has a wall, it's very thin. So that wouldn't be considered a cavity. So then I'm going to bombard you with a lot of labs or selected labs. So, the patient had a leukocytosis, the patient had an AKI, the patient was anemic. Their HIV lab, so their viral load was undetectable. Their CD4 count had dropped to 59. And importantly as well, their percentage was 10%. Their TB, IGRA was negative. They were negative for acute CMV, but had been exposed to CMV. Human T lymphocyte was negative. Their respiratory PCR was negative. Then their Aspergillus galactomannan was negative. Their beta-D-glucan was negative. Their toxo was negative. Mycoplasma was negative. Coccidioides was negative. The urine was negative for Legionella and histo. The sputum was positive for MRSA. And even though this doesn't look like PCP, their DFA was negative as well. And their acid fast was negative again. Their inflammatory markers were raised, but I think what's more impressive is that the ESR was higher than the CRP. or so high that they actually stopped counting after 120. Autoimmune labs, because they were also being worked up for this AKI, they had everything. So it was all pretty unremarkable. They had a weekly positive P-ANCA, and their C3 complement was like mildly reduced. And then frustratingly, their bronch was negative for acid fast, negative for malignancy, but they did actually do a tissue biopsy this time, and it came back positive for Aspergillus. So, eventually the diagnosis was made that this was, Aspergillus and MRSA. And then, so a little bit about Aspergillus. So Aspergillus is a fungus, and it can have several different clinical presentations depending on its interaction with the host. It can be invasive pulmonary, aspergillosis, or it can be, an Aspergilloma. So an Aspergilloma is, so going from left to right, so you can see at the top hyphae in the tissue and then no hyphae in the tissue. So say starting on the right hand side, like an Aspergilloma is when someone has previously had a cavitary lesion, say TB, and the Aspergillus gets into the cavity and then kind of creates this fungus ball, but doesn't invade the tissue, doesn't invade the blood supply, and just kind of, continues to live there. And then the whole other spectrum is, if it invades the blood supply, invades the tissue, and the chronicity, it can be acute or it can be a bit slower growing. And then, does anyone know the treatment for Aspergillus?
Itraconazole.
Yeah, itraconazole or voriconazole. And do you know roughly how long you treat someone for?
I don't know. 6 weeks, I'll guess.
I think it's like 12 weeks. It's 12 weeks, and with like CT imaging to look for resolution. So it's a pretty big deal. So this patient, was started on voriconazole, was started on Vanc and cefepime, and was initially in the ICU, and was, say, stabilized, and then unfortunately deteriorated again. So went for another CT. So you can see this CT here. I'm not sure if anyone wants to have a go reading this, or maybe just for time. So the CT showed that there was a PE in the left pulmonary artery. So initially the patient was on heparin, then on Lovenox, and then was started on a NOAC. And one of the big things that cavitary lesions, they all have overlapping risk factors, like HIV, lymphoma, immunosuppression, neutropenia, things like that. But one of the common presentations that they have is hemoptysis. So later on in the inpatient course, this patient had lots of hemoptysis while they were being treated with a NOAC for this big PE and their cavitary lesion. So the diagnosis, they had massive hemoptysis from this invasive pulmonary aspergillosis, and they had this MRSA pneumonia on a NOAC. So just to talk about hemoptysis for a little bit, because it can actually be pretty scary, and it's pretty rare or uncommon for, I think, us to see like large volume hemoptysis. So it's important that we distinguish it from pseudo hemoptysis, that being, from the GI tract or the upper respiratory tract. And it's a little bit more common in people with chronic lung disease, about 10%. Annually, you're looking at 0.1% of all outpatients, and then inpatients 0.2%. So it's much rarer than, say, like an upper GI bleed. Nearly all of the cases are self-limiting. But one of the big things is the triage into mild versus massive hemoptysis, and the cutoff depends on the resource. But for massive hemoptysis, it's usually 300 to 600 mils over 24 hours, and it has a very high mortality rate. It's 50 to 100%, and the death itself, is caused by asphyxia, not from blood loss, because what happens is, while they're bleeding and they're losing blood, you're not so much concerned about vascular collapse as you're concerned for the tracheobronchial spaces filling up with blood, and the gas exchange being affected, and them becoming incredibly hypoxic.
Just to stay on this slide for 1 second. So pseudo hemoptysis, we talked about hematemesis and upper respiratory bleeding. Anybody else have any other examples of pseudo hemoptysis? Something which can appear like blood? This was a step 1 question.
Aspergilloma could also present as pseudo hemoptysis. Like if you just try to, like if the blood from epistaxis goes to the back and then you cough it out, it would be.
That's true. That's the upper respiratory, like the nasal epistaxis. So I think Shabari mentioned serratia pneumonia. That's true. So serratia and Klebsiella can cause reddish appearing sputum, which can also mimic blood. So that can also cause pseudohemoptysis. Thanks, Patrick. Go ahead.
Yeah, exactly. So you want to be sure, because it'll determine on who you call and what you do next. So the lungs have a dual blood supply. The pulmonary arteries and most of these most of the blood supply is from the pulmonary arteries, and then a little bit is from the bronchial arteries. Remembering that the pulmonary arteries are actually carrying venous blood, or non-oxygenated blood, and there's these anastomoses between them that form, and when there's either acute or chronic impaired pulmonary circulation or arterial circulation, this leads to neoangiogenesis, and proliferation of these anastomoses. So things that could cause this are infections like pneumonias, abscesses, PEs, chronic lung disease, chronic inflammatory diseases, and malignancies. And the hemoptysis originates from these bronchial arteries in 90% of the time. Because what happens is, the systemic pressure, these vessels have very thin walls, they're fragile, and kind of the shearing forces. So that's where this, that's where the hemoptysis actually comes from. This is just to kind of illustrate that. So here, this is the pulmonary artery. Remember, this is carrying, low oxygenated blood, and then this is the bronchial artery. And then it's supplying the vasa vasorum, which is supplying, the kind of the parenchyma. And in the space between the two, that's where you have all those anastomoses. And then you can see that if you imagine, they start bleeding, it's right beside the small bronchus there. So that's how the blood will then be communicated up. And this is just to kind of imagine where, the two circulations are connecting. So from the aorta, you have the bronchial arteries, and then from the pulmonary artery, you have, the smaller arterioles. So the causes then of hemoptysis, this is from a European paper, but in say the Western world, it's mostly cryptogenic, which I find surprising. But then certain airway conditions, TB is the largest cause globally. But then in say maybe the Western world, or cancers would be the main cause, after cryptogenic causes. Other causes then would be PE, but it's a very low. It's only 2.6, and then you have all these other subsequent causes. The initial management. So this again is something that I wouldn't have been too familiar with. So it's important that the patient continues clearing their airway, because that's what will determine how well they do, obviously. So you want them to actually continue coughing up the blood. So obviously you want to check their vitals. You want to give them oxygen. If you can, you want to try position them with the bleeding side down, meaning that if they're bleeding out of their cavitary lesion in their left upper lobe, you want to position them with their left lobe or their left lung down, and that way the blood will hopefully not travel and affect healthy lungs. If you can, a little bit of sedation, and then endotracheal intubation versus if you're in a specialist center and they can do endobronchial intubation, to try protect and seal off that healthy lung so that the gas exchange isn't further impaired. This is an algorithm. Again, I couldn't find like a perfect algorithm for hemoptysis. This is from a European paper, and it separates them into massive versus non-massive hemoptysis. I think we're far more likely to encounter non-massive hemoptysis, so I'll kind of go through that. So it starts off, they recommend just getting an X-ray and using that X-ray to differentiate which side, the laterality and maybe the cause. So you might find a pneumonia, you might find an abscess, you might find a cavity, and if it's parenchymatous, then just kind of watch and wait and see what happens, because remember that over 90% are self-resolving. So just kind of watching and waiting. Again, going down this algorithm. So if it's negative, sorry, if the X-ray is negative, they can go for a diagnostic bronch, and if it's parenchymatous, then they'll go for bronchial artery embolization, which is successful in like nearly 100% of cases. And then say if it's endobronchial, then they can go for therapeutic bronchoscopy. That's where they do like stenting or maybe cryoablation and things like that. And then if it's massive, if you can stabilize the patient, send them for a CT and a CTPA, and then they'll go for a bronchial artery embolization. If they're too unstable, they can do bronchoscopy and they can try wall off the part of the lung or lobe that is bleeding, again to prevent it spreading to the rest of the lung and impairing gas exchange. And then, so the take-home points, so cavities then are, lesions that have, gas filled and have a wall that's greater than 4 millimeters. And a cyst is thin-walled and usually has a wall less than 2 millimeters. The acuity and the risk factors, help guide the diagnostic workup. But obviously, you want to separate infectious from non-infectious, and you want to rule out TB. Pulmonary aspergillosis is a whole spectrum of disease, and it can be kind of a benign aspergilloma just living in a null cavity, or it can invade the tissue and invade the blood supply and be devastating. Hemoptysis is relatively rare, but most of the time it's from this neoangiogenesis, from these fragile vessels, and it's arterial bleeding. So it's you're able to differentiate it because it's bright red. Most of the time it's self-resolving. Massive hemoptysis unfortunately has a very high mortality rate, and the death is from asphyxia, not blood loss. And then cavitary lung disease, the reason I'm doing both today is because obviously this patient had both, but they're both very closely linked to TB, and it's the main cause globally. So this patient, just to kind of finish, so this patient was a rapid and then became a code, had pulseless electrolyte activity, was intubated, and then had ROSC, and then went to the ICU, and then was transferred to the east side because they were either considering doing embolization or maybe doing therapeutic bronchoscopy. They did neither. Unfortunately, the patient had an anoxic brain injury and is trached and pegged on a medical floor. So yeah.
Interesting case, Patrick. Thanks. Any questions, anybody, or something you would want to discuss?
Just a very nice summary with the figures. I thought that was really nice. I missed the beginning because I was in a meeting, but I think this patient also was hard to get the bronchoscopy because I think there was a question about starting treatment or not for concern for aspergillosis, and then but there was an issue with trying to get that bronch done, if I remember correctly. And then the question regarding treatment, it's usually 6 to 12 weeks, but it just depends on response with imaging. And with her, it's also immune system, depending on how medicate the C4 response as well. So
thank you, Dr. Osorio. Yeah, so I think only for me, a couple of the take-home points. Number one, unlike in a GI bleed, these patients die of asphyxiation. So it's very important that you pay close attention to which side it is. And in him, like if you know the side in this patient, you saw that big left upper lobe cavity. So you have the bad lung down because you don't want to drown out the good lung. And it's the opposite in a patient with like a lobar collapse and hypoxia, because in those patients you want the good lung down because the good lung needs to be perfused. So just remembering that differentiation. And the other thing is, just having a framework for hemoptysis as well, because we talked about the infectious causes, malignancy, some of the other causes apart from the autoimmune cardiovascular causes. So PE can cause hemoptysis, but CHF and mitral stenosis, they caused increased pressure in the left atrium that gets it gets transmitted to the capillaries in the lung, and that can also cause pink frothy sputum, and that can mimic as hemoptysis. And then one very rare cause of hemoptysis in a young female who is menstruating is catamenial hemoptysis when they have endometriosis in the respiratory tract. But I think we had a good discussion. We talked about lung cavity hemoptysis. If anybody has any comments or questions, we can.
I just had one question on that, if you don't mind.
Sure.
Hey, Patrick, thank you for the wonderful case. I was just wondering, does the Aspergillus itself cause cavity, or was there an underlying cavity from probably TB or something from in which the Aspergillus went and sat basically? Because I don't think just AFP is really very sensitive and specific for TB diagnosis. And we just did the BAL and the AFP staining, but I don't know how accurate it is to really rule out TB in this case, because I still have a high suspicion for TB in this particular case.
So this case was interesting because a lot of things were negative, even the serum fungal markers, the galactomannan and the beta D-glucan. I think you could be convinced that it wasn't TB just because the patient had two different sets of acid-fast bacilli, both at West and at Morningside, and the patient's quantiferon, their IGRA was negative as well. So Aspergillus can cause, like I said, that spectrum of disease. So it can cause a cavitary lesion as a, invasive Aspergilloma, invasive aspergillosis. But it can also be, that benign, relatively benign kind of fungus ball, the Aspergilloma, when it finds, it's inhaled and just resides in a cavity from, say, TB. So when you have like an Aspergilloma, it's usually because someone had TB, had a cavity, and then, or had, say, COPD, and then, the Aspergillus got into it and formed an Aspergilloma. But it can definitely cause cavitary lesions as well.
Then Eric has asked in the chat, for these patients with an established diagnosis, what is the role of covering them with cefepime and vanc? I understand that the MRSA was positive, but nothing grew. So just the rationale for, was it just in the period before the bronch, or did the patient get a full course or a long course of vanc and cefepime?
So I'm kind of giving a highlights of the case. I think the sputum grew MRSA. So, it was to make sure that there was no, in case there was like a bacterial element while the bronch happened, because like Dr. Osorio was saying, everyone was very concerned about repeating the bronch because the patient was, tenuous at times, and the risk of the bronch was considered to be high. So, it's a relatively low risk, but high benefit treatment. Half our hospitals, half our patients, I feel like, are on vanc. So this person, I feel like, definitely warranted a bit of vanc. And then later on, I didn't include it because this patient had so much going on, but later on, I think the patient actually grew MRSA bacteremia. So it was definitely, at risk.
Sounds good. All right. If no questions, so we can call it a day then. Thanks, Patrick. Great case.
Yeah. Thanks, guys.
Patrick. Thanks.
Thank you.